Hello, everyone, and welcome. My name is Erica Christensen, and I'll be your moderator for today's webinar, MDI Myth, Nobody Cares About or Uses MDI Data. Our presenters today are Dr. Deirdre Amaro, the Chief Medical Examiner for the Utah Office of the Medical Examiner, and Dr. Michael Staley, the Suicide Prevention Research Coordinator for the Utah Office of the Medical Examiner. So without further delay, I will hand things over to our presenters.
Okay, good morning, good afternoon. Hello, everyone. So we're going to be talking to you today about the MDI myth that nobody cares about or uses MDI data. In short, I care about it, Michael cares about it, ergo, myth busted. Any questions? Just kidding. We will talk more than that. Okay, so I'm going to give you my forensic pathologist perspective on why MDI data matters. Going to start with sort of an overview of the medico-legal death investigation landscape in the US. Going to focus on how I see the medical examiner coroner's office as a public health entity, not just a criminal justice entity. And then talk about what is mortality, how is MDI data used for mortality data and in surveillance systems that go beyond just mortality data. And it is a little bit weird to not be able to see anyone's face, but this is the day and age we're in, so I will persevere. Oh, and so Michael is going to talk about this. Michael?
Yeah, I'll be talking about some applied ways that we've used MDI data and built up more MDI data just beyond cause and manner in just a minute.
Okay, so let's talk about medical legal death investigation landscape in the US. This is very US specific. I don't know much about the international landscape, unfortunately, but I would like to change my perspective. So if I were to summarize the medical legal death investigation landscape in the US, I would summarize it as this. Kind of a dumpster fire, a mess of a bunch of different systems. Every jurisdiction does things a little bit differently, has different standards, different resources, different expectations. And as a medical legal death investigation professional, this is extraordinarily frustrating. So here is a map of the US, obviously from the CDC, depicting the different death investigation systems in our nation by state. And at a very simple glance, you can see that it is a mosaic patchwork, hodgepodge mixture of different systems. So some states have county-based mixtures of medical examiner and coroner offices, like where I was in Missouri before this. Some states have county-based or county or district-based medical examiner offices. A few states, like Utah, have centralized state medical examiner offices. And then many states have county or district-based coroner offices. So I've worked in New Mexico, which is a statewide medical examiner system, which is from a data standpoint fantastic because every death that falls under a jurisdiction comes to one centralized office, which has a more standardized resources, expectations, and way of doing things. I've worked in California. California is mostly sheriff-coroner counties or coroner standalone counties. So when I worked in California, my boss was the sheriff, which is the highest elected law enforcement official, and he was also the coroner. And I've also worked in Missouri, which is mostly exclusively a coroner or medical examiner jurisdiction based on county, and that distinction is based solely on population level. So once the county reaches a certain population threshold, they get bumped from a coroner jurisdiction to a medical examiner jurisdiction. But that doesn't mean they actually have forensic pathologists doing the work. The level of qualifications are very different across every different jurisdiction. I've seen some jurisdictions where the minimum qualification to become a coroner, aside from being elected, is that you have to be 18 years old and have a GED. In Missouri, in order to become the coroner, you have to be elected and be 21, have lived in Missouri for a year, and have lived in that county for 6 months. Those are the only requirements. Now, I'm not knocking any of the individuals working in these systems because the vast majority of people I've worked with in medical legal death investigation across the board are dedicated, caring folks who want to do a good job. The problem is the system. So let's back up a little bit. Want to make sure we're on the same page talking about cause of death versus manner of death. These are two of the things that we put into death certificates, which are very important pieces of information or digital paperwork. So the cause of death refers to the injury or disease process that made someone dead then. And there are infinite different ways of phrasing a cause of death, right? It could be positional asphyxia, could be metastatic colon cancer, could be glioblastoma, could be blunt head trauma, could be gunshot wound of chest, et cetera, et cetera, et cetera. Manner of death, however, is multiple choice, right? I'm assuming we all know this, but manner of death is either manner of death natural, accident, homicide, suicide, or undetermined. And then some jurisdictions, like in New York City, I believe there's a therapeutic complications option. So here is a pie chart depicting the manner of death, cases divvied up by manner of death for our Utah office at the medical examiner's office, which is a statewide system in 2023. And I like to highlight this division of cases we encounter by manner of death because most people, right, most people outside of our medical legal death investigation profession assume that most of what we encounter as medical legal death investigation professionals are the manner of death homicide cases, right? That's what's always shown on the cool CSI TV shows where they're working with cops trying to figure out who done it and leading to prosecution of the bad guy. But most of what we do are not manner of death homicide cases. That is usually the smallest slice of the pie. The largest slices of the manner of death pie are either manner of death natural or manner of death accident. And in Utah, unfortunately, we have a large slice of the pie of manner of death suicide. Doesn't matter what office you are in, though, this distribution is fairly consistent. So even when I was in far rural Northern California working for a sheriff-coroner, the homicide slice of the pie was one of the smallest slices of the manner of death pie. Most of what we encountered was manner of death natural and manner of death accident. Now, I pilfered this from the Cook County, Chicago Medical Examiner's Office website, highlighting even a big, crazy, highly densely populated city medical examiner's office. Still, the manner of death homicide is one of the smallest slices of that pie. Most of what they encounter are manner of death accident and manner of death natural. So these manner of death natural cases could be, a middle-aged or older person who either never went to see a doctor or is not currently under the care of a physician or doesn't have any documented potentially lethal natural disease and they suddenly die. They become our responsibility to figure out why they are dead. What natural disease processes were they carrying with them? This could also be the young athlete who suddenly collapses on the field from a suddenly previously undiagnosed heart condition. And by doing our postmortem examinations, we can diagnose the heart condition and do potentially postmortem genetic testing, which can potentially help inform the surviving family members and help them get appropriate screening and care so that they too also don't end up on our table. Manner of death accident, a lot of these are drug overdoses because we do have a drug problem in our country, no matter where we are. And then a lot of traffic accidents and just weird ways people die. So yes, we are a criminal justice entity, and it's very important the work we do there and how we interface with law enforcement and the legal system. But I would argue that more than a criminal justice entity, we are a public health entity because we see the terminal results of public health problems, right? Things that are killing people in our community, they come to us. When people are dying because they're texting while driving, we see that, we collect that data, we notice that, and that data helps inform public health strategies to try to prevent those deaths. So there's an article I really enjoy referencing. It's from 2017 Academic Forensic Pathology. It's called Public Health Impact, How Medical Legal Death Investigation Data Helps the Living. To quote from the article, in aggregate, death certificates tell a larger story about the health of our communities and the nation as a whole. Medical examiner and coroner offices are often the first to see trends that are killing people in our communities, like, carfentanil or other weird opiate drugs that are coming into our communities and killing people. We see that. So in 1979, Susan Baker, who was an autopsy tech at this office, I think it was in Baltimore, noted that infants seem to be dying at higher rates in car crashes than older children. She thought that was kind of odd, stuck in her brain. She wondered if it was just something that she was seeing or if it was actually some trend that was playing out broader. So she was able to access the death certificate data from the National Center for Health Statistics. And she discovered that it wasn't just her office, it wasn't just her brain telling her that they seem to be dying at higher rates. It was a national trend. Because of that, because somebody noticed, hey, babies are dying at a much higher rate, we were able to think about why might that be. And as a direct result of that, we had these infant car seat laws in place, which ultimately decreased the infant death rate. So our medical examiner coroner offices are uniquely positioned to catch these trends in what's killing people, which then informs public health and safety interventions. And then furthermore, we were able to monitor, are those interventions effective or not? And I think we can all agree that the infant car seat laws have been pretty effective in decreasing baby deaths from car crashes. So mortality data. This is the CDC houses this nationwide repository of mortality data based on death certificates. It's part of their National Center for Health Statistics and their National Vital Statistics System. They also look at birth certificates information there. And I pilfered this from the CDC website as well. The purpose of mortality data, right, is to monitor trends in public health issues, identify health risks, assess prevention and screening programs, allocate resources, funds, plan health facilities, services, identify areas for medical research, and determine death benefits and settle estates. That's a lot of stuff that mortality data plays a role in. So how do we get from what we do to mortality data? And I think most medical legal death, maybe medical legal death investigation professionals don't understand this connection. I would say most physicians and healthcare providers don't understand this connection either. So the oversimplified version of how we go from what we do to mortality data is from the death certificate. That's where it starts. So we, or a coroner, a healthcare provider, certifies the death certificate with the cause and manner of death. There's the demographic information that the funeral home helps fill out, all that information. The death certificate then gets registered by the local health department and sent to the statewide health department, where they assign it a preliminary code. And then it's sent to the National Center for Health Statistics. At the National Center for Health Statistics, a team of nosologists, people trained in coding these things, assign ICD-10 codes to the causes of death on death certificates. ICD-10 codes are the same codes that are used for every medical diagnosis, even for live patients. And so once they get the ICD-10 codes, that becomes mortality data. And so different public health entities, different researchers, different legislators, politicians can access mortality data to try to implement changes. So I'm going to give you an example specifically from California. So California Department of Public Health, this is one way that mortality data is used. So the California Department of Public Health has a Center for Health Statistics and Informatics. They have the ICD-10 codes, mortality data for California-related things, which is made available to various research groups and local health jurisdictions. But in order to access the California mortality data, you have to apply and get approval from a Vital Statistics Advisory Committee. And the minutes here are public online, so I went through them. Just to highlight, these are some of the research projects, the studies that are being done that rely on mortality data. And I want to highlight how these are the kinds of studies that are used to eventually inform patient care, live patient care, how clinicians treat patients, live patients, and it relies on mortality data. So again, our mortality data, our death data is informing how live people are treated. And again, the oversimplified summary of this is that the death certificate gets turned into mortality data, which informs the public health strategies with resource allocation and how the research that is performed, ultimately with the goal of improving health. But as anyone who's ever worked with, data knows, if you have garbage going in, then your garbage is going to come out, right? So if we have crappy DCs, then we're going to have crappy data points going into mortality data. And how the heck are we going to have meaningful strategies derived from crappy data? This is infuriating. But it goes beyond just the mortality data, the important work that we do, right? So there are many different national surveillance systems. Michael's going to talk a bit more about some of them. One of the big ones is the National Violent Death Reporting System, NVDRS. This relies heavily on the work that we do in medical legal death investigation. And they're trying to understand the why. Why are people dying violent deaths? Because if we can understand the why, then we could potentially prevent future deaths. We also have the State Unintentional Overdose Reporting System, the Medical Examiner Coroner's Alert Project. This is a cool surveillance system where when consumer products come out and we notice in the medical examiner coroner world that people are dying related to these consumer products, people can be alerted to the potential danger. Like when the lithium button batteries came out and little kids were like, ooh, shiny object, let me eat it. And then they were dying from having the battery in their system and causing fistulas. That's something we need to know so that we can tell parents and caregivers, be very careful about this and hopefully prevent future deaths. So my last point here, I believe, is that we as a medical examiner coroner's office, we get a perfect cross-section of the communities we serve, right? We see everyone from an intrauterine fetal demise to a 100-plus-year-old granny who took a fall and broke her hip, to everyone in between, no matter what color, what religious affiliation, what political affiliation, what sexual orientation, how much money you have or don't have, what your health insurance is. If your death happens and falls under our jurisdiction, you come to us and we take care of you. And then my final point before going over to Michael, right? So most people assume that what we do is just for the decedent and maybe for their family, but that is just the tip of the iceberg, purple pyramid. So yes, we tell the decedent's story. Why is this person dead? Which is important for telling that person's story, but then it's also important for their surviving family, giving them an answer, giving them information, and providing that death certificate, which is important for all these different after the fact financial business reasons. But it goes beyond that, because with the death certificate data and the data from our death investigation, that's informing our local, regional, and national public health entities, because we see the terminal results of public health problems in our communities. All right, take it away, Michael.
Well, it's good to be here. Thanks for this opportunity to tell you about ways that we're pushing epidemiological work into our work at the Utah Office of the Medical Examiner and making that data actionable. Go to the next slide, please. So you all are familiar with the work of forensic pathologists and coroners across the country determining cause and manner. We add a piece to that because we recognize the charge in our work goes beyond determining cause and manner to public health, just like Dr. Amaro spoke about. And we call this applied forensic epidemiology. There are, as far as I know, about 35 applied forensic epidemiologists across the US. We are rapidly growing thanks to efforts like OD2A and other funding opportunities from CDC, NIH, and Department of Justice. We really want to do two things, which is to make our data timely and to make our data complete. We heard repeatedly back in the mid-2010s from policymakers and legislators here in Utah that they were frustrated. They knew that the rate of suicide was increasing in our state, but they were frustrated that they were getting and expected to act on data that was 18 months or sometimes even 2 years old. And so they wanted a better timely record of who is dying, where, and possibly why. The second piece here is data completeness. Sometimes we find a body in the middle of the desert and we just simply don't know much about them. Sometimes they go on unidentified for an extended period of time. And to really respond from a public health perspective to a death, we need more information than simply that this person was found in this particular way with this particular item in a locked residence. And so that's where getting complete data informs our public health response to these untimely deaths. Next slide. We have multiple other aims, though, going beyond just making sure people get data quickly and complete data at that. It's also to make sure that our data isn't siloed off. Data sharing is a really big deal, especially in this day and age of informatics, where we can build systems. And I'm going to talk about one of the systems we built today to really make sure that our data is being shared on a daily basis with our partners, and so they can respond. It's about making sure our data can integrate with other records like the health facilities database, the all payers claims database, so that we're pulling in as much information as we possibly can about decedents so that we can have that, again, complete response. And lastly, which I'm just going to touch on today, is postvention, and that is that crisis and bereavement work that comes for the living. A lot of jurisdictions might call this out of scope, but indeed, I think this has been one of the most valuable parts of the work that we do with the Office of the Medical Examiner here in Utah. I always knew we would need to engage in this work, but its value has really given a lot of purpose and meaning behind why we're collecting all of this information and data. And I'll talk briefly here at the end about how postvention is prevention. It's not just a nice thing to do, it is active public health. Next slide. The first system I want to talk about here today is called SUDS, the Sudden and Unexpected Death Surveillance System. We started interviewing one next of kin for every Utahn who dies by suicide back in 2017, late 2017 and early 2018. And then we expanded this program to include accidental drug overdoses in 2020. We aim to do this interview about 4 to 8 months after the death. Now, we got way behind during COVID. Our staff, like many of you, probably were pulled in multiple directions during that period of time. And we are just now starting to approach that year mark, let alone the 8-month mark. One of those lasting effects of the pandemic, but we are catching up. And anytime I get discouraged, I've got a great staff that's like, no, we can do this. They're really amazing people. I want to fill in the purpose of these interviews, which occur well after the death, is to fill in gaps of knowledge and about circumstances leading up to the death. But also part 2 is to surreptitiously, incognito, provide bereavement support, this postvention support to families and social networks. And even though we're a year behind, or sometimes even later right now, we're encountering next of kin who are failing to do very basic tasks like maintain hygiene or go to work or whatever the case might be. And we're able to offer resources. Whether they take them or not, that's up to them, but we're able to help maybe steer their ship in a slightly better direction. Next slide. So part of what these interviews yield is better demographic information. Funeral directors, as Dr. Amaro said earlier, gather some demographic information about whether or not they served in the military, if they were a veteran. It gathers information about their employment and education and things like that. But we know that there are many other dimensions to demography that can inform our public health response. And that includes the relationships that they were in, the number of children they have. We know that suicide has a genetic component. And so making sure that with his family knows that suicide is now part of their family history, just family health history, just like heart disease and diabetes and Alzheimer's and whatever else. We also get a lot more information about employment and financial hardship. It's one thing to mark unemployed, but it's another thing to mark unemployed and disabled, or unemployed and they really did want a job and they couldn't find one, or they were disengaged from finding employment. Those are all different aspects of employment that we don't get from death certificate data. We also ask about housing status, namely if they were experiencing homelessness ever or and up to the time that they died, and whether their housing was stable. There's been a recent national push, thanks to Margaret Warner at COMEC, the Coordinating Office for Medical Examiners and Coroners, and others, to really gather housing status as part of one of those fundamental demographic components in mortality data. We also gather information about religion that's particularly important for suicide, but also many other kinds of death. Sexual orientation and gender identity are not part of any death certificate that I've ever seen in the United States, and yet, again, critical components. There are multiple groups out there, the Postmortem Project, Dr. John Blosnich from the University of Southern California runs that, and Juniper Fedor from Georgia also did some really great presentations at the National Association of Medical Examiners on how to do this and do it well. And also, we get more information about whether and how this person served in the United States military. Next slide. We also add on a lot of circumstantial information. We get these narratives, which can be really complete and wonderful and comprehensive. And oftentimes we get very minimal information from our death investigation narrative. And maybe the police, assuming that this death was a suicide, also didn't gather a great deal of information. And so it's up to us to fill in the gaps of how this person got from wherever they were to suicide or accidental drug overdose. Or we also look at maternal deaths as well. And so we look at various domains of information like connectedness and attachment. Did they feel like they belonged in their community? Did they have people that they could trust in a crisis? We look at their traumatic experiences, both in childhood and adulthood. That helps us understand how and whether or not the treatment they received, if they were treated, was adequate to meet their needs. We look at their criminal history. Now, this is self-report. We also have ways to look at criminal history through actual looking at, a criminal database here in Utah, but we want this self-report as well. We look at their medical history, and that includes both diagnosed and undiagnosed symptoms. You may have heard the statistic that about half of people who die by suicide have no history of a suicide attempt, and they really were never treated for a suicide. This group is really enigmatic to public health because we really need to find places to engage with this group that's not engaged in behavioral health. And these interviews give us and point us to gaps and opportunities to do just that. We examine their prescription medications and the ways that they were engaged or not engaged in therapy, whatever that looks like, perhaps prescription only, perhaps talk therapy only, and ideally both. We do an extensive inventory of alcohol use and misuse, and that goes all the way through tobacco, marijuana, and drug use history as well, including changes in those kinds of behaviors leading up to the time that they died. And finally, we take this really comprehensive inventory of suicidal risk factors and warning signs. Next slide. So since October 2018, we've completed about 1,600 interviews for SUDS related to suicide. Next slide. And since December 2020, we've completed about 600 interviews related to drug overdose deaths. We have about a 65% participation rate on the suicide side of the house, and on the drug overdose side of the house, it's about a 55% participation rate. Next slide. So we use this information that we gather from interviews to improve our fatality reviews. The Department of Veterans Affairs just released a really great funding opportunity to boot up or support fatality review committees in local jurisdictions. I hope that many people will take advantage of that. But so often we go to these fatality reviews and we might have the information that we got from a police investigation or from our medical legal death investigation, but we didn't really know a lot about this person outside of the way that they died. These interviews help us to provide a lot of context to the ways that people were engaging in care. I lead a fatality review committee currently that focuses on the zero suicide framework. So we're engaged with our healthcare partners to conduct these reviews. And we can talk to them and give them feedback about the ways that this person was engaging with their treatment or not engaging. We may have found, all of their prescriptions for their psychotropic medication unused, and the doctor didn't know that that was the case. And we're able to provide that feedback so that they can better systematically deliver behavioral health care that works. Next slide. I want to talk about the fatality information death system. And because we're public health, of course, everything has to have an acronym. And so we call this FIDS. And this is the database where we put information related to fatality reviews. You can go to a fatality review and you can review 4 deaths. And then you can dismiss, you have your set of recommendations, you have your findings about these people who died that you reviewed, and you come back a month later or 3 months later, and it can be almost like you're starting over from scratch every time. And we've noticed that our data would have so much more power and endurance if we could collect it and put it in one place and analyze it. And that's why we've been developing FIDS. The system isn't up and running yet. We're using ARPA funds to develop this with our Division of Technology Services here in Utah. And the way that it will work is a lot like Maria. Many of you who participate in maternal reviews, I don't know what Maria stands for, MMRIA. You can Google that. CDC has a beautiful webpage for it. But it allows for data providers to put in information about a decedent, and then for that information to be relayed to reviewers in a de-identified way, so that when we come to the table to talk about this decedent, we're able to be prepared, and people have had time to actually look at these timelines of events and to build really good recommendations on how that death could have been prevented. And then also to compile these from across multiple fatality reviews. Here in Utah, we have an overdose fatality review, a suicide fatality review, a child suicide fatality review, domestic violence, and that doesn't even include the system level reviews that review deaths that were state involved, from child and family services, et cetera. And we know that when I release 70 recommendations out of a suicide fatality review, and overdose does the same thing, policymakers and leaders even in our Department of Health are going to be completely overwhelmed. And so we need to push our recommendations together to come up with, say, 5 recommendations that policymakers can really engage with and come up with solutions. And that's what FIDS will help us do. Next slide. We also do this near real-time mortality surveillance. Every morning I sit at the table with the physicians who are on that day, with the death investigators who are relaying information, and we're gathering information in real time so that we're making sure we inform our stakeholders, including legislators and healthcare professionals, of what's going on in our state related to suicide. We release a monthly report for suicide and a quarterly report for drug overdose. If you were to start this program in your state or your jurisdiction, I would strongly recommend starting with quarterly reports. I would love to stop doing monthly reports, but we just got a lot of people now that if they don't get that monthly report on time, they come knocking at my door. But this allows us to detect suicide clusters, particularly in schools and in jails and prisons. Jails and prisons, they're pretty good at finding them anyway, because they're very closed environments. But schools, not so much. We've also been able to identify suicide clusters in, say, club sports that are not school sanctioned, but this group of young people knew each other. We've also been able to find anomalies in drug-related deaths, and I'm going to talk more about that in just a minute. Next slide. The point here is that timely data drives a good public health response, and ultimately that leads to saving lives. I know that the crisis deployments that we've engaged when it comes to schools especially have saved lives, because we've been able to get crisis workers and trained personnel on the ground at school before students are notified that their classmate, their friend, their teammate has died by suicide. And they're adequately able to get the students that are most directly and deeply impacted separated from the rest of the group, and also to identify other students within their school that may be vulnerable. I'm really proud of the work that we've done in schools here, in partnership with schools here in Utah. And I think that we've ultimately seen that, in addition to some other suicide prevention work, reduce our our suicide mortality with youth. It's one of the only age groups in Utah where we see a decrease in the last couple of years in suicide. Next slide. Just like I said, these are early alerts of potentially contagious suicide deaths. And you might think suicide is contagious. Yes, there is. Yes, it is. There's a lot of really good research out there. Madeline Gold is sort of the matriarch, if you will, of that research. You can look that up. And then more recently, Anna Mueller and Seth Arbutron have released some really interesting research related to suicide diffusion and contagion in schools. Next slide. During the COVID-19 pandemic, you may have heard along with us from lawmakers that if we were to implement a public health strategy or restriction, if you will, that the response to that would be that people will take their own lives, that they'll die by suicide. We could speak to this, we could provide feedback in real time here in Utah because of the way that we monitor suicide death and overdose death. At the onset of the pandemic in March 2020, we built our own incident command center where we were meeting with our public health partners, our healthcare partners, schools, et cetera, and we were reviewing what was going on week to week. History, had we been looking at history in March 2020, would have told us that we're not going to see these increases for 2 years. And indeed, that's exactly what happened with suicide here in Utah. But we could speak to lawmakers who were reticent to implement public health strategies during COVID-19 to say that, masking actually hasn't led to increases in suicide mortality or even suicide morbidity. We really had a great feedback system during this period of time so that public health professionals and lawmakers and local officials could do what they needed to do to control the spread of COVID-19. Next slide. And so now I want to talk a little bit about our suspected overdose surveillance system. Next slide. This is a really unique opportunity for medical examiners, whether they be coroners or forensic pathologists, whatever the case might be. They're really well suited to know what's going on with overdoses. Maybe you've heard of tenazidine and perhaps an increase in tenazidine, this veterinary tranquilizer essentially that's been showing up in some street drugs. We can speak to that in real time in Utah. We have not seen an increase in tenazidine. And so to put a lot of resources into preventing tenazidine related mortality, probably not our best strategy, at least for now. We should be prepared for it. Probably not our best strategy for now when we're still seeing increases year over year in the proportion of fentanyl involved deaths. But medical examiners, because they're so close to these deaths and they're looking at these toxicology reports in real time, are really well suited to provide this information. Next slide. So we wanted to speed up the notification period. Now, speeding this process up is no easy feat. Trying to take toxicology that takes 6 to 8 weeks from our local lab, our state lab, moving that forward really not really feasible. And NMS, we can't afford, frankly, to send all of our talks to NMS. But even with an NMS shorter turnaround time, it's still not fast enough for us to respond. I want to give a shout out here to my colleagues in King County in Seattle. They've done a similar process as us, but they've used a qualitative detection system for drugs, and they've really been able to hit the ball out of the park when it comes to early alerts in drug overdose. So it took days, from when the death occurred to the investigation, the examination. We send out our samples, and it took on average about 34.4 days to receive toxicology backs from our local lab. And then we had to certify it. And then we could say that this is what's going on with drug overdose in our state. This could be a months long turnaround time. And when you've got a public health emergency, months might as well be years. This just is not sufficient to respond adequately to an aberration in drug supply or whatever the case might be. Next slide. So what we did was come up with a definition that we've continually improved, by the way, over time, as we've figured out which factors tend to reproduce both sensitive and sensitivity and specificity. There we go. More specific results. And so for a long time, our physicians were getting a piece of paper for every case, and they were checking the boxes on this form. And I'm not going to go through this form, but they were checking what was present. And at the end, they could say that this was a probable overdose, a possible overdose, or that it was not likely to be an overdose. And then that form was collected by our drug overdose epidemiologist, Megan Brockmeyer, who really deserves all the credit for this system, by the way. This is really her baby, and she's done such a great job implementing it. And she would enter this into a system that would be picked up by our informatics team automatically every week, and it would update an internal dashboard so we could detect it. It also would feed data into an algorithm. We're still using that algorithm that would detect an increase in drug overdose mortality. And also that same algorithm is using non-fatal overdose reversals so that it's picking up on both of those things at the same time and able to issue these aberration alerts. We have since been able to incorporate this drug overdose form into our case management system. And so no one has to sit there keystroke by keystroke entering zeros and ones into a giant spreadsheet. It's automatically put in there. And now that overdose aberration algorithm, as well as our internal drug overdose dashboard, are being updated on a nightly basis. Every 24 hours it refreshes, which has really brought us to as real time as I think we possibly can be, unless we do even more faster refreshes. Next slide. So what happens when we get an aberration? First of all, we're notified of that aberration. It doesn't get pushed out to our local partners right away. And it's up to Megan or whoever's reading the aberration on that day to decide if this is a real aberration or not. Now, Daggett County in Utah, if you know Utah, it looks like kind of a park bench. The Daggett County is the part where you'd sit. And about 900 people live in that county. And so if they have one overdose death, not only do they have an aberration alert, but they also probably now have the highest rate of overdose in our state. From a public health perspective, this is why we look at counts and rates, because those rates are not always reliable. They're not always going to tell us the truth. And so we're probably going to tell Daggett County that there was an overdose, but we're probably not going to activate our SURE system, which is the response to get more naloxone, our needle exchange folks, and our other harm reduction efforts out to that location. Now, in Salt Lake City, in Salt Lake County, where really is a population dense area, those aberrations tend to only happen when there is a real bad batch or something is actually going on that we need to respond to. And so once we get these aberration alerts, we notify the county within hours. The county just deploys their SURE plan, and that's that harm reduction service. Our law enforcement partners are typically brought in on what's going on and what they need to do. They'll put more patrols in that area where we found the aberration, and we're making public health happen based on our data within 24 hours of detecting that aberration. Next slide. So that's this yellow line here, this suspected overdose notification. We couldn't speed up that toxicology result, but we could speed up the rate with which people were notified about these deaths. And we found that our positivity rate is about 80%. So when we get the tox results back down the road, we know that we're about 80% accurate. And here's something, I got a PhD in sociology, and you don't really publish science unless you're pretty darn sure. And in public health, sometimes you got to take what you know and run with it. And that's been probably one of the hardest lessons for me to learn in public health. And so 80% accuracy, I wish it were 100%, but 80%, pretty darn good. And I would rather have green medicine like naloxone and harm reduction on the ground and be a little bit wrong, 20% of the time to be exact, than to do nothing. Next slide. All right, last thing here, and I know I'm talking a little longer than I should have, but I want to talk about post-vention prevention, and specifically when we engage with families. And we've given our death investigators tools to do this. We've given our pathologists tools to be able to do this. And a lot of this work comes from the folks that do these interviews. We know that suicide and overdose and drug misuse and alcohol misuse, these things have generational patterns, both genetically, by the way, and sociologically. And we want to deploy strategies that are not just based on depression, but that are specific to treating suicidal behavior that can break those generational patterns. And that's where we take these families that have these histories and we take them to places that can provide the specific kinds of treatment. You know, you would not go to an oncologist for a 99% blocked mid-LAD. In behavioral health, we sort of think like an LCSW can do everything. And we have to move away from that. We have to be better about training LCSWs to treat grief, period, but also suicide-specific grief and overdose-specific grief. And so we take these people to people who can actually help them. We also deploy interventions for entire groups like families, schools, things like that, so that we're getting the right resources to the right people at the right time. And we provide interventions for people experiencing a crisis. This isn't rare, but we do ask everybody that we interview, are you thinking about ending your own life? Are you thinking about suicide? And are you thinking about killing somebody else? Are you thinking about damaging somebody else's property? And we've had yes answers to those, and we've known what to do. I'll admit it's shocking, but we've known what to do, and we've intervened and gotten those people the help they needed in that moment. Next slide. So we send out resource cards. They look like sympathy cards. They say you are not alone, and they've got a lovely forest scene on them. And they say we're sorry for your loss. And also on the back, they say you should scan this QR code and get engaged with this bereavement resource. We use the grief questionnaire, the BGQ, when we interview people. It sounds like I'm just asking you how you're doing, but really I'm conducting an assessment so that our peer untrained, they're trained, but they're not LCSWs that are doing these assessments, can actually make a decision based off of a numerical value and know how and where they need to refer the person they're talking to. And again, get in mobile crisis outreach teams involved if we need to respond to an immediate crisis. Next slide. We also, after these losses have, gone by multiple years later, there are some people that just want to be involved with the work that we do. We've got a Survivors Council for suicide and a Survivors Council for overdose. And any question we ever ask a suicide loss survivor or overdose survivor goes through this council. We make sure everything that we do is vetted and gets feedback from a council meeting. And that just makes our work all the better and informed and sensitive and accurate. And we're not doing something we shouldn't be doing by speaking to these families. Next slide. And there's our contact information and a beautiful picture of Utah. It's ugly. Don't move here. Yeah, as you can see, it's a terrible place to live.
Yeah, it's a real trial being here.
Yeah. And that's it for me.
Thank you.
Excellent. Well, thank you both for providing such an informative presentation. It was great to see how the Utah office is really, engaging the community. So with that, we will jump into our question and answer session. So please continue to submit those questions to the Q&A pod. But as we get started, our first one is for you, Dr. Amaro, kind of an overarching question. Having worked in several different types of states, which death investigation system did you find to be the best? Or I guess that's a personal description or definition, I suppose, but I guess what's your experience working in different types of offices?
Right. So I have worked in a variety of different systems. And each system has its own unique challenges, and they're, something that one system is not doing well, sometimes another system does better. But I would think from the public health standpoint and from the standpoint of getting good data on death, a statewide medical examiner system is the way to go.
Makes sense, especially when you were talking about the aspect of centralizing data, right? Like those systems can only talk to so many other types of systems, and those statewide kind of gives that bonus. Dr. Staley, do you have anything to add to that? I'm not sure if you've worked in different types of environments or not.
I haven't. I'm from a state that is a sheriff's coroner system as well. And I'm working with some states that over the years, they're like, okay, we want to do what you're doing in Utah, and they're not centralized systems. And I'll tell you that, we don't have to negotiate a data sharing agreement with 56 coroners in Utah. We can just press go. So there are some advantages, and yet those coroners who have local jurisdictions probably know the family of the person who died, and they're probably trusted, and the family's more likely to open up to them than they are Joe Q public servant, me, sitting in Salt Lake City, who's calling them to ask them very personal, intimate questions about the person who died.
Absolutely. And that actually leads us into our next question really well. It's they asked, do you have any strategies to kind of increase interview participation that you found successful? As you said, kind of cold calling can have mixed effects.
Yeah, we've tried a lot of different things over the years when it comes to trying to get more people to get those participation numbers up. By the way, 65% in social science is unheard of. 55% is unheard of. So I'm actually not too concerned about our participation rate. I actually think it's really good. I can tell you what didn't work, but we would be here all day. I think that the timeliness is really key. The further you get away, well, you shouldn't call within that 4-month window. People are in shock. They're just trying to get through the day. And you're probably, the potential to do harm actually exists within that window. And that can exist for some people up to 6 months. But if you can get that 6 to 8 month mark, you're going to find the people that, of course, they're still grieving, but you're going to find the people that are not grieving well, and get them, the people that are at risk for prolonged grief, complicated grief, increased substance use disorder, whatever the case might be. That's when you're going to be able to find those people and direct them to the places they need to go. By the way, that participation rate is the number of people who actually do the interview. We give a lot of people who don't want to do the interview, or they just feel like they can't. We still direct a lot of those people to support.
Excellent. Thank you. And again, I was quite surprised by the participation rate. That's great. And I was curious, do you think coming from a community like Utah, where there is, a different cultural and religious beliefs around drugs and alcohol, those types of substances, do you think that plays a role in your community?
It absolutely does. I'm not so sure how to answer that question. When it comes to stigma, that's there for suicide, and it's also there for overdose. And what that ends up doing actually is isolating people who've lost somebody to suicide or overdose. And oftentimes our phone call and our sympathy card is one of the only ones people get. I'm not going to say that's a common experience, but that happens. And sometimes we're the only person who's called to ask about them. And we're the first opportunity that's been ever provided for this family member to talk about the person they lost.
Excellent. Wonderful. Thank you for that. So next question, is there any sort of cost associated with using the fatality data systems that you guys had mentioned?
Well, I don't come cheap, but I'm just kidding. But so these are all internally developed systems. We've never, we use a REDCap database to store our interview data. If other states or jurisdictions want to do this, I will send you the XML file if you've got the REDCap access, and you can upload it and press go. We would absolutely share with you FIDS. I don't own that. I can't say that the state wouldn't charge to, distribute that system more broadly. But right now, we don't have any mechanism for sending out those systems. And so as far as I know, they're free.
Wonderful. Thank you. That's always great to hear, especially within our community, as we know. Next question. Is it possible, kind of this user asks about the incorporation of AI tools to help connect data and to gain effectiveness and efficiency in monitoring psychotropic drugs? Have you guys utilized any of that growing kind of technology when looking at your interview data or even your medical record data?
Not yet. And that is because of a lot of, I think, unanswered questions by the data privacy folks here at Department of Health and Human Services. It's always a tension about how much information can we put into AI that is technically PII, and where that information is going. But that is 100% the future. we get so many data points that we collect and we code, but there's also all kinds of data points that we don't actually code because we just can't. And I mean, we don't tell interviewers, were they a veteran? Yes, no, unknown, or refused, even though that's what the codes are. We just ask the question and they answer it. And they might give us something entirely different. And we still have to code it. But if you can let AI have the actual raw data, I know that's going to lead us to something really powerful, particularly when it comes to psychotropic medication and looking at those, because, organizing that data is a real challenge.
Absolutely. One more specific question for you, Dr. Staley. Is the Safe Utah app still successful, being further developed? And are your crisis responders collaborating with the app, or is that a separate system?
So we don't have anything to do with the back end of Safe UT, but it is absolutely still out there. It is an app that we know schools are using a lot. It's also been deployed for our National Guard, Utah National Guard. It's also been deployed for frontline responders, first responders here in Utah. It's pretty new with those groups of people, and so I would say it's still in the up curve on onboarding part of that. But we definitely encourage families who have kids to sit down and, for their family time, download the app and try to use it together so that they know when they're experiencing a crisis, this is a tool that you can use and no one even needs to know.
Excellent. If there's any little follow-up, we are so grateful for you guys. As you said, the presenters shared their information earlier. We'll also have contact information popping up on the screen. Thank you all once again for being here. And feel free again to contact us or the FTCOE and check out the rest of our Mythbuster series to learn more. Thank you all.
As you depart, we kindly ask that you take a minute or two to complete our post-event questionnaire. The link will be pasted in the chat and also appear as you exit the Zoom room. Your feedback helps us improve our outreach efforts and continue to provide the best experience possible. Thank you again for attending, and we hope everyone has a great day.